Yes, I got it.
Okay.
All right, everybody. So as you just heard, we are recording this meeting. We'll go ahead and get rocking. So good morning, everybody. I am Becky Huckabee. If you don't know me, you probably should. I'm one of the, just kidding. I'm one of the program managers for JBBS. This is the, if you did not know, this is the JBBS quarterly meeting. This is our first meeting of the calendar year, which is pretty exciting, pretty cool. I'm stoked. We have a very packed agenda today, so we are going to get rocking. I will let my colleague first, Kelly, introduce herself, and then anybody else with BHA, I would love for you to introduce yourself as well.
But we just need to switch it.
Good morning, everybody. I'm Kelly Russell. I'm the other JBBS program manager. Appreciate you all joining us today, and it's nice to see everyone. I'll pass it over to Alex.
Hello, I'm Alex Clayton. I am the Criminal Justice Monitoring and Evaluation Coordinator for the BHA. And just a reminder that if you're not speaking, make sure you mute so that we don't get any interruptions while speakers are talking. And I don't know, is there anybody else from the BHA here who wants to introduce themselves?
Not today. We didn't get any supervisors or anything today.
Core team, yeah.
All right, so you just get to deal with Kelly, Alex, and myself today. So lucky you all. Before we get into any presenters, I do have a couple of announcements. So sit tight. I'm going to make these as quick as possible. I think I've got 3. So first announcement, invoices. So your invoices are due Monday. I had to check the calendar real quick to see when that was. So invoices are due Monday, which is January 20th. I've shot a couple invoices back within the past couple of weeks because our fiscal folks are now telling us that invoices cannot have just a typed signature. It needs to be either a wet signature that you actually print out, you sign, and then you scan that and send it in, or you create an actual electronic signature on your invoice. That's what I do. I create an electronic signature, on the invoice to actually sign and approve your invoices. So if you need help doing that, if you can't figure out how to do that, please reach out to me. But if it's just a typed signature where you just type your name, I will be shooting those invoices back to you for an actual signature. Second announcement, fiscal year 26 contracts. We are starting to discuss that. I know it's only January. I know you have until June for fiscal year 25, but we need to start planning as soon as possible. So those fiscal year 26 contracts and discussions are beginning. During your monthly meetings with Kelly and myself, we more than likely will be talking to you about your budget for fiscal year 26. We no longer are going to send out send us back a best case and worst case scenario for your budget, because we really just don't have the capacity to do that. We are going to be going off of spending this year, as well as the changes that were made earlier this year with the amendment process. We are still planning on having SOR funds next year. So if you would like any large changes with your contract or anything, please discuss that with your program manager within the next couple of weeks, because Kelly and I will more than likely start that budgeting process around mid-February or so. Quarterly report. So we will be starting a quarterly report process. We nixed the annual report a couple of years ago in favor of the monthly contract monitoring tool. And we've been playing, as you have seen, we've been playing with the monthly contract monitoring tool throughout the year to make it a little bit easier, a little bit more flowy, I guess you could say. So it's easier to fill out from month to month. That has necessitated us to get a quarterly report out. That should be coming here soon. I believe, Alex, you were saying by the 20th, that quarterly report should be sent out.
Yeah, by the 21st, because the 20th is a holiday. So I'll send it out the next day. And we're calling it a quarterly survey, just so that you don't get confused, because it'll say JBBS quarterly survey. And that's meant to refer to the previous quarter. So that'd be October, November, December. So that covers those 3 months. And then in April, there'll be another one for January, February, March, right? And then in July, there'll be one for April, May, June. So it'll always be kind of a month after the quarter ends, and it's kind of referring to the previous quarter. So just to clarify.
Thanks, Alex. Appreciate that. So please be on the lookout for that. There will be some questions that more than likely your med vendor or your contractor will be required to answer. So please get with them. We'll give you plenty of time to fill it out. You're not going to have a week turnaround or anything like that. You'll have quite a bit of time. Actually, I have 4 announcements too, not 3, but anyway. So, third announcement: the JAG and SKIP grant announcements did come out. I believe last week. Excuse me, they went out last week. These are DCJ announcements for grants. But they're pretty big announcements. If you would like to apply for a JAG or SKIP grant and you did not receive that announcement, please let myself or Kelly know and we can send that to you. These applications are due March 10th, so it's a pretty quick turnaround. So they were released January 6th and January 7th. JAG was released on January 6th, SKIP was released on January 7th, and they have a turnaround of March 10th by 5 p.m. Those need to be submitted. So please make sure if you are interested in those, you get those into DCJ. Last announcements: the CCJC conference is coming up. So the Colorado Collaborative Justice Conference will be April 8th and 9th. I didn't write down the date, but I believe those were the dates. That announcement will be coming out, fairly soon. We will be getting an email out to program coordinators today. We have limited spots this year. We don't have a ton of spots. So we are inviting folks to come to that conference. We do have spots available. We're going to send an email out with a Google form for you all to fill out if you're interested in attending that conference. Please be cognizant and send the folks that only need to be sent because, like I said, we do have limited spots. You can pay to go to that conference. Our spots are free, but it's super limited this year, so just be aware of that. Those are my announcements. Kelly, anything to add to that or anything that I missed?
Nope, I think you got it all. Thank you.
Cool. Awesome. Thank you.
Thank you for talking. I'm not feeling all that well today. So Becky, thanks for taking the reins on this. I appreciate it.
Yeah, sorry. I should have said something, but I just keep rocking, All right. With that said, I'm actually going to pass the conversation over to Alex and Brent just briefly. We got about 5-10 minutes for them to touch base. So Alex and Brent, once I find you, Brent, I'll make you a co-host too in case there's anything that you need to share. But go ahead and go for it.
Awesome. Yeah, thanks, Becky. So just to follow up real quick on the annual survey, that'll go out on the 21st and you'll have until the end of February. So February 28th or whatever. So that'll be about 37 days. So longer than you usually have for the monthly contract monitoring tool. So there'll be ample time. I wanted to talk about the changes to Civic Core real quick, and then I'm going to pass it over to Brent to talk about the dashboard that we've kind of been mentioning the last couple of months because we are really close to going live with that. So let me start with Civic Core. I'm just going to share my screen so that everybody can see what that looks like. Okay, so of course it's not working with me. Here we go. All right, so can everybody see this? This is the Civic Core referral list. Can everybody see that, Becky? Is that showing up?
Yep.
Okay.
Yep, we can see that.
All right, cool. So pretty standard. First of all, we updated the logo, which is really cool. Up in the right-hand corner is still the old logo from like 10 years ago. So that's updated. But the big thing that you all need to know about is right here at the top, we've added a definition for successful versus unsuccessful discharge. A successful discharge being somebody who's completed a treatment plan in custody as outlined by JBBS staff, and that there are clear steps outlined to execute the treatment plan in the community upon release. Versus an unsuccessful discharge is somebody who had in-house disciplinary action like fighting staff or another inmate or substance use. The client chose to disengage, which we'll call willful noncompliance, or a subcontractor dismissal. So because of harassment or repeated issues with noncompliance, lack of follow-up, et cetera. So we just wanted to add some clarity around what it means to be successfully versus unsuccessfully discharged. One of the things that we're seeing in the data is we're seeing some facilities with 100% successful discharge rate. For small facilities, like really small facilities, that might make sense, right? If you have 20 people in a year, it's feasible that all 20 successfully completed it. But if you're a facility that has like 400 people in a year and you have a 100% successful discharge rate, that means the something isn't getting recorded properly in Civicor. So we wanted to get that definition right here. If you have questions, there are obviously people who don't fit neatly into either one of these categories. So if you have some specific case and you want to know, hey, would this be considered successful or unsuccessful? Just reach out and let us know, and we can help clarify that for you on a case-by-case basis. The other changes that need to be shown is, so eligible for client services, that one's been there for a while. The client participation, no. The new one here is, was the client released before being admitted to JBBS? And this should account, we've heard a lot of stories from facilities about people who, somebody's been deemed eligible, they want to participate, and then they make bail, or something happens and they're released over the weekend and they get out before they can be admitted. So they can't get a gain. They don't get formally admitted to JBBS. So instead of just not putting those people in Civicor, we wanted to account for them. So there's this question here: was the client released before being admitted to JBBS? If you say yes, then nothing happens. You just click submit, you save it like that, and it'll go into the file. If you answer no, then it'll open up the rest of the form. Okay, so this is just one more category of people that are eligible, they want to participate, but then they get released early for whatever reason. And we wanted to track those people in Civicor. The other change here is when there's a question here: was the client enrolled in JBBS in this or another facility within the past 3 years? We had a similar question before, we just updated it. And now if you answer yes, and this is really important, it's going to ask a couple extra questions. It'll say, if so, where, which was, again, that was on the previous question. But now we have, okay, what was the reason for the rearrest? And you have this drop-down box with new charge, previous charge, or technical violation and failure to appear, or other. If you click other, it'll open up a little box and you can type it in. Then the other question is, what was the main contributing factor for the rearrest? Same thing, it'll be a drop-down box. You can say drug or alcohol use, experienced homelessness, mental health crisis, had no access to medications, did not follow up with community provider, or again, other. And if you click other, it'll pop up another little box that you can type that in. The reason that we're doing this is so that we have a better handle on recidivism. We want to know not only what the recidivism rate is, but why are people coming back? If somebody's in JBBS in a prior instance, prior time that they were in the facility, they were in JBBS and now they're back, we want more information about why that might be. That allows us to kind of have a better understanding of the recidivism, and also to start targeting funds and priorities at programs and different things that might be able to address those recidivism concerns. So just, that's a big focus for us going forward, is focusing on recidivism and understanding not just the rate, but why are people coming back and what can we do to try and kind of address that. So those are the big changes. I wanted to say before I pass it over to Brent, we have an office hours scheduled for January 29th. If you have questions about this, you can email us. You can email me, Becky, or Kelly, or if you want to have like a bigger, broader conversation, we can set something up, and then we'll have office hours on the 29th where we'll talk about this in more detail. So all those opportunities for you to ask questions of us and kind of clarify this stuff is in front of you. We definitely don't want to put more on your plate unnecessarily, but this was a key piece that we wanted to put forward so that we could really start understanding this stuff that's part of the JBBS mandate. Okay, so that's all I have. I will pass it over to Brent. Brent is our contractor. He's been working on the dashboard that we've been talking about. Again, that dashboard is really close to going live. My hope is by early next week, it'll be live, and I'll send out the link. It'll be located on the JBBS website. And I'll tell you exactly how to find it and stuff. And then the instructions for how to use it should be really clear on the dashboard. But I wanted Brent to just kind of go over each one individually so that you have an idea of what you're looking at the first time you look at it. So Brent, if you're there, I will pass it off to you.
Sounds good. Nice to meet y'all. Let me just get this share going. Ooh, that's not that good. Alex, is there a chance that you, my operating system is upset with, Zoom is upset with my operating system? Is there a chance you could open up the dashboards? I can still talk about them, but yeah,
Yep.
Sorry about
Give
this.
me just a second. I got it here.
Yeah, for sure.
Okay. Okay, that should be the map. Can everybody see that?
Yeah, we can. Okay. So, all right. So there's several tabs here. You can see them up at the top. So we'll sort of talk about each one of these quickly, but yeah, so what And then actually, we're first going to talk about the filters over on the right-hand side. These also appear on every tab. So first is the date range that you're looking at. We have these preset to look at last fiscal year. We'll probably, once the fiscal year rolls over, we'll probably swap that over to the next year, but you can change those dates to look at whatever time period you want. Then you can filter by some demographic information for the clients. So by their race, their gender, their age, the county they were from, which doesn't really make sense to do on this map, but on the other pages, you'll see why you might want to do that. So you can look at just your data. Yeah, and then that's just the key for the map here. So what the map is showing is this is all the counties that had any active participant in JBBS during the time period you have selected. So this is last fiscal year, basically. And so as you mouse over, you can see how big the county is in terms of its population, its jail characteristics, as well as how many people were in JBBS. So yeah, got to make sure you're entering your data or you won't show up on the map. Also, it's just a small side note. There's 1 or 2 sites where that's the case. So yeah, okay. So admitted clients over time. This one's pretty straightforward. It's just the one additional filter that shows up on this one, that date granularity. If you flip that, you can look at it by by week, how many people were in the being admitted each week, each day. So you can get a sense for the flows into the program overall or into your specific program at whatever time period you're interested in.
If I could jump in here just really fast, and I don't want to interrupt the flow, but Brent, would you mind just kind of telling everybody who you are? I realized we didn't really introduce you or have you introduce yourself.
Oh, sure.
Can you kind of just let people know how you fit into this puzzle here?
Yeah, so I'm a data scientist who works as a contractor for, one of the things I do is a contractor for the BHA. And so I build some software to help make analytical things possible and then also do analytical things. So want to be able for everybody involved in the program, but also the public to be able to have a sense for what's going on with the program. We can also, the dashboard, this currently is set to last fiscal year, but you could look at like the last week if you wanted. So this gets updated every day, basically, with the information that you put into Civicor. So it's basically real time. So anyway, yeah, that's me, and that's what we're doing here. We'll be doing some more work going forward. Maybe talking with all of you again. We're going to be doing some looking at recidivism and that sort of thing next. But anyway, yeah, good to meet you all. So yes, thank you, Kelly. That was a good idea.
And for this map, this JBBS admitted clients over time, you can filter and look at just your county over here on the right-hand side with this list of counties. So you can look at just your county. You could compare yourself to the neighboring county, right? You could look at all large counties, so that you can filter not just by age, gender, and race and ethnicity, but also by county on this. So the date range is really variable, which is useful. And then you can look at just your county over time. So
yeah. All right, client demographics. This one can be quick. This is just the number of people coming into. So again, this is by their admission dates. This is people coming into the program. Of all the people who came in the time period that you select, what is their demographic profile? So breaking them down by ethnicity, age, and gender. And then the next page here, this one we'll talk about maybe a little bit more. So here we're looking at the admission rate by their demographic profile. So each of these bars you're looking at, this is no longer people who are admitted. This is all the referrals who are coming in that time period. And the blue is people who were admitted, and orange is people who are not admitted. And so what we were, one of the things we were looking for here is variations in, we don't want to be treating different groups of people differently, basically. There is some variation here, and we have a little bit more work to do, but there's nothing super glaring. So that's good news, but something that we'll for sure keep an eye on going forward. Okay, so this chart, this is showing you 2 things on the same chart. So one, the left-hand side axis and the orange bars are tied together, and that's showing you the number of people who were admitted by county in the time period you have selected. And then the blue dots are tied to the right-hand axis, and that's showing you the admission rate. So you can see that there's a lot of counties here where the admission rate is 100%. And so that's probably not true, right? So that's reflecting the fact that some counties probably aren't recording all the people who are getting referred. They're just writing down the ones who they enrolled. And so that leads to this wonky data, right? So just want to make sure we are recording it accurately, because we actually don't have a good sense for what the real admission rate is across the program, given that it might be that the average that's shown right here, high 80s, that's real, or it might be it's more like the 70s. But we just want to make sure everybody's recording everybody who gets referred, not just the admissions, and then this should start to look a little bit less skewed across counties over time.
Same thing on the other side where we have extremely low admission rates in some of these counties, right? That'd be a good conversation at like, okay, what's going on? Why do we have 15% in Summit County or 26% in Clear Creek? Anybody who's kind of below that average, we kind of want to have a conversation. Okay, what do the procedures look like in that county in terms of admission, right? And
or referral. Are they sending a lot of people to you who just aren't right? They don't understand what the program is,
right? And they're not. They shouldn't be referred in the first place. So anyway, this is the kind of stuff that allows us to start having those conversations.
Yep. All right, and so then this next one, this is looking at, again, all the counties across the x-axis, and now we're grouping people, the selector in the top right for date now, we're looking at when they get discharged. So currently this is set to all the people who are discharged in last fiscal year across all the counties. And so the blue is the successful discharges, orange is unsuccessful, and the red means it wasn't recorded one way or the other. And so, of course, we always want it to be recorded. So going forward, I think it's mandatory now, right?
Yeah.
Okay. So
I'll change it to the current fiscal year, and you'll see that change.
Yeah. So that's good. But again, we're seeing some super high variation here, and a bunch of counties that are 100% successful. And so again, that sort of suggests that maybe not just sort of hitting successful for everybody who discharges, whereas we really do want to know if they're unsuccessful versus successful. It's not a bad thing if they're an unsuccessful discharge, right? That's not bad. We just want to know. We want to know what's really going on. So,
and when we talk about recidivism down the road, that's going to be helpful because we'll be able to compare people who are successfully discharged to people who are unsuccessfully discharged. And if we're seeing a higher percentage of people that are unsuccessfully being discharged versus success, that means JBBS is doing something. If somebody successfully completes the program, they're less likely to come back than somebody who unsuccessfully completed the program. But we can't make those kind of connections. We can't draw those kind of conclusions unless the data that we're pulling in is really, really accurate. So that's why we defined it in Civicor for you, so that it's clear what success versus unsuccessful looks like going forward.
Yeah. And that's the kind of thing we need to put together to like make the case to committees and legislators to make sure that the program is continues to be supported. So yeah, that's all the pages we've got here. These will be publicly available soon, and so y'all, anybody in the public can use them whenever they want. And this might be helpful for you as you're trying to understand what's going on, but also as you have questions to answer going forward. So on surveys and things like that. So anyway, nice to meet you all. Thank you for sharing impromptu there, Alex. I have to appreciate that. And yeah, great meeting you all.
All right, great. Yeah, and that's why we wanted it to be public, right? So that you all can use it, we can use it. It's not just private to the BHA. It's out there for everybody to use at any time. And so that was the reason for that. So I'll pass it back to Kelly and Becky and just say thank you for your time this morning. Appreciate it.
Awesome. Thank you, Brent. Thank you, Alex. Appreciate you guys. If there are any questions, please let us know. And as Alex said, if there are any questions about GAIN or Civicor, please let us know in that GAIN office hours call on January 29th. Yeah, what we're going to do now is we're going to go ahead and introduce, if I can find her, Hannah Hall with Healthcare Policy and Financing. Hannah, are you here?
Hello. Hi, Becky.
Hey, so I'm going to pass it on to Hannah. Hannah, I will let you do your own introduction, but Hannah's going to be presenting a bit on the 1115 waiver and talking to you all about that process. So I'll go ahead and stop and let Hannah do her thing.
Thanks, Becky. Is there a certain time that you want me to wrap up my portion?
I think we've given you roughly, I think mostly as much time as you need. I think by about 11:45, if we could wrap up, because if we have time, one more presenter today, but I think that should be plenty of time for you.
All right, folks, buckle up. Hopefully this will not be an hour of me talking. I want to share some information and then really dedicate a good amount of time to hearing from all of you. So as Becky said, my name is Hannah Hall. I am from the Department of Healthcare Policy and Financing, our Colorado Medicaid agency, and I am our criminal justice policy advisor. One of the main projects that I'm working on right now is the set of Medicaid reentry services that we will be offering through our 1115 waiver. And I'm here to provide some information, some updates, and then get some feedback from this group. I'm going to share my screen, which will take longer than it should because I'm not used to Zoom.
We're all used to Google Meets, guys. So when we're saying we can't find the darn button, it's because we all use Google Meet. So please bear with us with Zoom.
All right. Are you all looking at what looks like the right presentation for this meeting?
Yes. Yeah.
Lovely. I have so many tabs open. So, this is the list of information that I am going to go over today. I wanted to start with just some high-level information on what Colorado Medicaid is, what we cover, some of that introductory information, and then we will get into where this really applies to all of you and specifically the criminal justice space. So, starting off high level, I'm not going to go super deep into this because I know that you all working in the jails where folks typically can't access their Medicaid benefits. This is something that a lot of individuals are not going to have access to during incarceration, but so that you're aware of what folks have access to when they get back into the community. Medicaid covers, in Colorado, we have expanded Medicaid. We cover children, adults. It's based on income, disability, and pregnancy. Folks don't get charged copays or monthly or annual fees to utilize Medicaid. And we have some upcoming expansions in both continuous coverage, health-related social needs. Those will be kind of interesting for this population that we're talking about. This is kind of specific to the behavioral health services that are covered through Medicaid. This lists out the different buckets of coverage. When it comes to paying for coverage for any one individual, there are other factors to be aware of in terms of whether or not Medicaid can pay. Those would be, of course, whether the person is enrolled in Medicaid, that they are a Medicaid member, that the person providing the service is enrolled as a Medicaid provider. And then there will be requirements around whether medical necessity for that individual in that situation receiving the service that in general is covered by Medicaid. And you all should have access to all these slides. I'll make sure I think you might already have them. If not, we'll get those sent out to you so that you can reference back this information. I know this is a very long list. Now, this piece of Medicaid is going to be more relevant to all of you. In Colorado, we have RAIs. Those are regional accountable entities. In Colorado, we are a partial managed care state. And so we have managed care entities, our RAIs, who are responsible primarily for the behavioral health component of the Medicaid services that individuals have access to. So RAIs are managing our behavioral health benefit. They are contracting with providers who are providing the behavioral health benefit and helping members kind of navigate this whole system. The graphic on the right is probably not something that you need to know in terms of how the money flows to the raise. But I think where the raise are going to be really, really helpful to the jails, and where they're going to come into reentry services is partnering with Raise so that they know when members are getting out of jail. I know that already happens in places across the state, so that they can step in and then provide the care coordination that we pay them to provide, and really help the member navigate services once they're back into the community. So Raise are an important piece of that puzzle in terms of having someone to refer members to really help them as they are making that transition back. Also, I didn't mention this before. If there are any questions, comments that come up throughout, please feel free to interrupt me. Come off mute or raise your hand. I will say I'm not seeing the chat, so I'm not sure if there's anything in there.
Not yet, Hannah. We'll keep an eye on it as well.
Thanks, Becky. So another place that we get a lot of questions when it comes to serving the criminal justice population is with peer support services. Medicaid does cover peer support services. We have a website specifically for these services that some of my colleagues have done a great job of building out that really explains what services peers can provide, the requirements for those service providers, what it looks like to enroll peers to provide Medicaid services. And then we also have a specific inbox here if any questions come up about peer related Medicaid billing. And then this is a page about what Medicaid can't pay for. So I pull this up as suggestions in terms of when you have other funding sources or grants that you're looking at. These are suggestions of where we can dedicate those funds to pay for things that Medicaid can't pay for, and really looking ahead to the future and when we're going to start talking about reentry services. There are going to be things that Medicaid can pay for. So looking for Medicaid to be that sustainable funding source for the services and the things that we can cover, but knowing that there are going to be things that Medicaid that cannot be billed, Medicaid cannot be billed for. Some of those would be administrative, direct payments or incentives for members. That is something that has come up often. Recruitment and retention fees for providers themselves, capital investments, as well as marketing, outreach, engagement activities. One small caveat I will add to this is, and I'm going to ask you for your feedback on it a few slides from now, but we do have kind of a one-time bucket of funds coming from the federal government for planning for Medicaid reentry services. And so this list will not hold true for that grant funding. We will be able to invest in another list of things that I will provide when it comes to the grant funding that we're going to apply for readiness for reentry services. But in terms of what is typically a Medicaid billable service, it would not be things on this list. Red flags when it comes to billing Medicaid. If you're going to bill Medicaid for covered services, in your case, reentry services, we cannot charge members for covered services. So you cannot charge members and then also bill Medicaid. We also cannot send Medicaid members to unlicensed or unenrolled providers. The provider, in order to bill Medicaid for a service, the member has to be a Medicaid member and the provider has to be an enrolled Medicaid provider. When it comes to treating substance use disorders, we have to use ASAM tools, follow ASAM standards. And then, you know, when we're going through this, when it comes to reentry services, we will provide guidance around what it means to bill Medicaid, what are the provider types that will be allowed, what are the services that are going to be allowed, exactly how that should be billed, all of those things that we will work through together as we're planning for Medicaid reentry services, but definitely good things to be aware of. Now, this is where it gets really specific to criminal justice, and probably a lot more relevant to all of you, is when we're talking about expanding services in jails, juvenile facilities, and prisons. I think a lot of you have probably heard a number of times that Colorado has an 1115 demonstration waiver. This slide kind of describes at a high level what a waiver is. And I like to share this because an 1115 waiver in Colorado, it is not specific to reentry. I think in my world and probably in your world, we kind of associate the 1115 waiver with reentry. But we have a number of services that we're authorized to provide as Colorado Medicaid through the 1115. So you may hear about the waiver, and depending on where you're hearing about it, it may mean a few different things. At a very base level, 1115 waivers allow states to test or pilot innovative solutions that aren't otherwise allowed by federal regulations. And so when we're talking about reentry services, we're talking about, there has been, since the inception of Medicaid, the inmate exclusion policy. And so Medicaid has been primarily unable to pay for services for individuals when they are incarcerated. In order to offer reentry services, we had to seek an 1115 waiver because we want to try something that is otherwise unallowable. Colorado has had an 1115 waiver since 2021. That is how we were able to begin offering residential substance use disorder services. And that SUD waiver is what we submitted an amendment to include reentry services. That same amendment included some other requests for IMD facilities, for continuous eligibility, and we submitted another amendment to this existing waiver for housing. So if any of you are involved in those other spaces, you may be hearing about the waiver. And just know that there are a number of programs and a number of services that we have authority to offer, all under kind of this same federal authority. This is what I was just describing in terms of reentry services specifically. As we are all very well aware, there has been the Medicaid inmate exclusion policy, that federal prohibition on Medicaid covering services during incarceration. Currently, Medicaid can pay for inpatient hospital stays of 24 hours or more. So if someone is in a facility and goes to a hospital, even if they are still in your custody or considered incarcerated, if they go to a hospital, receive inpatient care there for 24 hours or more, Medicaid can pay for that. So if any of you are not utilizing that ability right now, please let me know. I know inpatient hospital stays can be very expensive. That is something Medicaid can already be paying for. But what we're looking towards in the future is expanding a certain set of Medicaid services immediately prior to release. And we submitted this application to CMS to do this in April 2024. Very exciting update. Our waiver just got approved by CMS like 48 hours ago. The press release has not come out, but you all are hearing about it now. So we got approval for our amendment to offer reentry services. Still waiting for one more piece of federal approval to allow us to implement, but really excited to share that amendment application was approved. Becky.
Hey, Hannah, you do have one question in the chat.
Yeah,
they're asking.
Thanks, Kelly.
This is specifically for 2765 designated facilities, right? That's the question.
Is that for what I was talking about, paying for inpatient hospitalization?
That's correct, yeah.
I'm going to write that down and double check on it to see if that designation is a requirement. And that was you, Ben. Want to make sure you get this answer.
Yeah, it was. I was just kind of curious as to like that sometimes happens for our jail that someone goes to inpatient, whether it's with our agency or not. But also wondering if it would be news to me if it would be an option for other Medicaid, like substance use focused programs. So that's why I ask.
Yeah, I think that I think you have it right. It really is kind of what like just hospital, like inpatient hospitalization. So that would have to be the setting. But I'll make sure that I dig a little bit into like that specific designation, just make sure there aren't any other locations where that might be available. Yeah. So talking about the future state of Medicaid coverage in jails and prisons, we are going to talk both about the 1115 waiver that we just had approved and how this relates to the Consolidated Appropriations Act, Section 5121, CAA 5121. I know folks have been hearing about that, and so I'll be touching on that as well. All right into it. CAA 5121. The Consolidated Appropriations Act is the federal budget bill that gets passed every year. 5121 was a section of the CAA of 2023 that created minimum standards for services that we have to provide specifically to incarcerated youth. I know incarcerated is not typically a word we use when we're describing youth, at least in the youth system, although there are some eligible juveniles who would fall into the jail scope. One thing to note when we're talking about juveniles is that this legislation used the Medicaid definition of juveniles. And in our world, juveniles go up to age 21 and up to age 26 if they're former foster care. And so that's where we may be seeing more juveniles in a jail setting by Medicaid definitions. Now, the effective date for these requirements was January 1 of 2025. HCPUF's strategy for Colorado is that we are going to achieve CAA compliance through the implementation of our 1115 reentry services. And so that's really where our efforts are focused. We have been, attending lots of meetings with CMS, who is our federal counterpart. And what we've heard is that across the nation, pretty much no states are ready to be fully compliant with the CAA right now. And CMS is supportive of us phasing in our compliance. And so from our side of things, what we're reporting to CMS is that we are going to become compliant with the services that Medicaid has to pay for through CAA by rolling out our 1115 waiver. Yeah, Becky?
Yeah, there's just one more question in the chat from Ben Hannah. And Ben, feel free to speak up as well, but so everybody can feel free to speak up as well. But he's asking, would you like questions about Medicaid billing while clients are in jail now or at the end?
Let's do billing questions at the end, just in case I answer it.
Cool. Thank you.
Yeah, thanks. And so that's kind of where HCPUF stands when it comes to CAA. We have to kind of submit to CMS what's called a state plan amendment that attests to our CAA compliance. For us, that is due March 31st for a January 1 effective date. And in that documentation that we send to CMS is where we are going to kind of formally, we have already had these conversations with them, but formally tell them that we are planning to achieve this compliance by phasing in reentry services. Our reentry services package will kind of cover everything that is mandated by the CAA. CAA requires targeted case management and then certain screening and diagnostics. And as I said, it's only for youth, and it's specifically for youth who are post-adjudication and 30 days prior to release. Since it's limited to post-adjudication, I think that would also really kind of bring down the eligible population who would be in a jail setting. But the 1115 reentry services that we are going to offer is for youth and adults. It is for everybody pre and post adjudication. There are no restrictions based upon kind of case status, and it is going to be 90 days prior to release. And so we're offering, and the services meet these minimum requirements. So we're offering more services to a larger population for a larger span of time, which will kind of meet the CAA minimum requirement. All right, seeing no questions there, keep on going. So now kind of shifting our effort to the 1115, because that is what we're going to move forward implementing the 1115. That'll put us in compliance with CAA. The goals that we're expecting to achieve through offering Medicaid reentry services are to improve connections to care for folks who are coming out of incarceration, since they're able to connect to Medicaid prior to their release, expecting to see better health outcomes, reduced recidivism, and increasing access to both physical and behavioral health care. Another piece of this is that we will be reinvesting any of our cost savings for the program. What that means is that any funding that the state is currently paying or using for services that will become Medicaid reimbursable, we will take the savings that we're going to experience by starting to bill Medicaid and getting a federal match. And those savings have to be kind of broadly reinvested into the same target population. So we'll be able to reinvest more funds in this population kind of outside of the limited services that will be provided through reentry. I'm going to skip the benefits because they're also in this table on the next slide. So as I was describing, all Medicaid and CHIP, that'll probably be less frequent in the jail setting, but all Medicaid individuals are going to be eligible for the services. There's no diagnosis requirement, no restrictions about pre and post adjudication, all of that. The services can be billed to Medicaid 90 days prior to release. And the three things that we're able to cover are MAT, medication assisted treatment, both the medications and any accompanying counseling, care coordination or targeted case management, including physical and behavioral health assessments, as well as a 30-day supply of prescription medications upon release. If you're wondering kind of where this list of services came from, this is a list that was provided to all of the states in federal guidance. Some federal guidance was released that let states know kind of what the minimum package, minimum requirements are for reentry services. And what we applied for and what was described in House Bill 24.10.45 that directed HCPF to apply for this waiver was exactly in line with that federal guidance. And so we kind of followed along with what we knew that the federal government would be supportive of and that we would be able to get approved in our waiver. Yeah, Becky.
Hannah, you just have a question in the chat. For those of us in the jail community wanting to be in compliance with this, will the state be putting out procedures and required documentation in a space that is easily accessible in order to allow us to access those materials? That's from the commander in Adams County.
Yeah. So, Tim, Commander, I'll take your question back. And I think I was recently emailing with you too. We're about to put some more information on our webpage, and then we'll send that out to all of you as well about CAA compliance. I can also share some resources with all of you. One relevant piece of this that I will mention is that, you know, reentry services for the CAA, they won't be billable to Medicaid until the dates of our phased rollout of reentry services. But CMS has released kind of some written responses to lots of questions about CAA. One of those was that correctional facilities can be compliant if they're offering the services regardless of whether they want to or choose to bill Medicaid. And so we'll share some more information, but for facilities that are kind of wanting to get ahead and looking at the CAA requirements prior to when we're going to be rolling out our 1115 reentry services, there are kind of avenues towards that compliance that don't require billing Medicaid for the services, if that helps.
Thanks, Hannah.
And so as we're talking about this phased implementation, this is the timeline that we're looking towards for Medicaid being able to pay for reentry services. These are the dates that are also outlined in House Bill 24-1045 that gives us authority at the state level to offer services. Of course, we need both the state authority and then all components of our federal authority to actually implement and begin paying. But the earliest date that we are allowed to pay for services in 1045 is July 1 of 2025 for state-run facilities. And then July 1 of 2026 is when we will be able to start phasing in jails and paying for services in local facilities. And this is not only for juveniles, this is for juveniles and adults. So should be everybody who is Medicaid eligible in your facilities. And it does include pre-sentence. So I apologize that we have to talk about CAA and 1115 because I think they have different eligibility requirements and that can make it a little bit confusing. But the 1115 services don't have any restrictions in terms of like age for adults. So it's adults and youth, and they don't have any restrictions based upon case status. Those where you saw youth and pre-adjudication was in the CAA 5121 minimum requirements. And so we're going to meet those requirements, but also offer the services to pre-sentence and adults and everybody who falls into that category. And then Sarah, you mentioned that often folks are released without prior notice. That is definitely something that we're thinking about in terms of the jail settings. As we are, working together over the next year and a half to kind of plan out how this is going to work, that's a consideration that we're going to have. One thing that I will mention is that if someone is released, 2 hours after they get there, there's only so much that you can do. I would think about it more in terms of if you do provide services to somebody while they are there and then they're unexpectedly released, if any of those services are Medicaid billable, then you can bill Medicaid. Other things we're exploring are kind of how we want to set up the timing of that. I know that release dates are unpredictable. And as we saw a few slides ago, the services are only Medicaid billable 90 days prior to release. So one of the options that we're exploring for with DOC and DYS right now that we can explore on the jail side is just doing retroactive billing. And so y'all are providing services. A lot of this is things you're already doing. A lot of you are already providing MAT. You're already doing some case management. You may already be releasing with some medications. And if we do something like retroactive billing, what you can do is wait until that individual is actually released. When they are released, you're going to know exactly what that 90-day span was. And then you could go ahead and bill Medicaid for any of these services that were provided in that 90-day window and have that not be coming out of your budget. So, and those are kind of what I'm describing now, where options, ways things can work, things that we've been thinking about, but no final decisions have made about how we're going to operationalize this and what it's going to look like. Those are the decisions that we'd love like your feedback and engagement on, so that we make sure to set this up in a way that's going to work.
Hannah, you had a couple more questions in the chat. Can you clarify, is this only for juveniles?
Kelly, we got those.
Oh, we did? Okay, I'm so sorry.
No, that's all right.
Them.
It's because you're all sick and you got stuffiness.
I've got so much cold medicine in me, you guys. I'm not sure which planet I'm on, if I'm being honest. So
We
back to you.
did just get one more chat though. Will we fall out of compliance by not providing the 30-day supply of meds if they release unexpectedly?
No. And so when we're talking about compliance, I think if you're talking about compliance with the CAA services, the 30-day supply of meds, it's not required by CAA. That's an extra service that we have authority to offer through the 1115 waiver. And so it's something that you can bill Medicaid for, but if somebody releases too quickly and you cannot get them the medications, if you don't provide the service, then you won't bill us, is kind of where that lands. And I think that's also something that we would, want to talk about as we're going through operationalizing, just like what are our mitigation strategies? What do we do when somebody releases unexpectedly? What can we control? And what is kind of outside of our control? This slide just kind of highlights how, at a very high level, how the funding will play out. When Medicaid pays for services, there's a state portion or a jail portion, and then there's a federal match. Depending on kind of the category that the individual falls into on our end, there are different federal matches that we get. Sometimes we get a 50-50 match with the federal government. Sometimes we get a 90-10 match with the federal government. When we were looking at the individuals that will be eligible in the reentry population, our estimates is that it's kind of going to average out to about a 77% federal match. So thinking that if the cost of a Medicaid billable encounter is $100, 77 of that we will be able to match with the federal funds that come down, and then the $23 would be what is the jail portion of that covered service.
Hannah, you do have one more question. Actually, two more. One just popped up. What is the exact list of things we will need to remain in compliance?
Is that with reentry in general, or is that a CAA question? Commander, I'll let you follow up. And then will the jails be billing Medicaid, or is the providers billing Medicaid? Great question. We have actually a few polls at the end of my spiel, and that's one of the questions that I'm going to turn around and ask you, is if you want to explore the jails providing the services and billing, or a few other options. It doesn't have to be the jails. If you have providers doing Enreach who are providing the service, we can set it up so that the providers are billing us directly. If you have a contractor providing the services, then we would just want to figure out what's your preference. Like, does the jail want to bill us and then pay their contractor? Do they want the contractor to bill us and then reduce the amount that they're paying the contractor? All of those things are options in terms of what we're allowed to do. Facilities themselves can bill Medicaid, and providers like community-based providers doing Enreach can bill Medicaid. And so both of those are options, and what we just need to determine is kind of how we want it to work. Sorry if that was a non-answer, but could be either. For CAA compliance, I will follow up with additional information about that. I am just pausing to make myself a note on my follow-up list. All right. Now, in terms of preparing for 1115 reentry services, these are things that you can be thinking about doing now if you want to be getting ready to be able to bill Medicaid. Knowing the set of services that Medicaid will be able to pay for, you can invest now in building up those services. I know this is something that's already happening in a lot of places. Y'all are offering MAT or doing care coordination or providing medications upon release. But if you are not, now could be a time to look at that, invest in kind of the infrastructure that you need to offer those services, knowing that Medicaid will be able to pay for them. Another thing to consider is HRSN efforts. That is health-related social needs. Another component of our 1115 that is separate from reentry services was an HRSN amendment. And HICPUF requested authority to pay for housing and nutrition services under Medicaid. When we have talked to you all and other criminal justice stakeholders in the past, one of the things we hear most often is that housing is the challenge in terms of getting folks out and helping them be successful in the community. Having somewhere for them to release to is one of the biggest challenges that we, have heard repeated over time. And so I'm really excited to kind of explore the HRSN component of this amendment and how that could be beneficial to our reentry population. And then last thing on this list is the reinvestment opportunity that I mentioned briefly earlier, is that we will have to track these funds in a way to know how much we're saving that was previously paid for out of state or local budgets. And so we're gonna need to track those fundings and then come up with a plan for how we are reinvesting those funds back into the same target population. That is, as I mentioned, a federal requirement when we start pulling down federal funds to pay for these services.
Hannah, did you get to Cassandra's question here in the chat? I wasn't sure. I was kind of multitasking.
So then would the jails have to do something to be able to bill Medicaid? Cassandra, if you want to come off mute, can you explain that question a little bit more to me? Make sure I'm understanding exactly what you're asking.
Yeah, so would the jails have to be like in federal compliance in order to bill Medicaid for services that are being provided in the jail?
So kind of at a very high level, the two biggest pieces that I'm thinking when it comes to being allowed to bill Medicaid is that we'll have to be making sure that individuals, the folks themselves that you are serving are enrolled as Medicaid members. And then whoever the service providers are going to need to enroll as Medicaid providers in order to bill Medicaid. And so I think one of the big roles of the jail, which I have on the screen now, is the making sure that you have a Medicaid application process in place. That is kind of part one. We won't be able to pay for services for anybody who is not a Medicaid member. So making sure that all of, all the folks that you're trying to bill for are able to get through the Medicaid application process will be really key. And then when it comes to the jails, like if you want to have jail staff provide a service and then bill Medicaid for it, the jails would have to enroll those staff members as Medicaid providers. And so those are kind of the two components. It's making sure that both the member and the provider are enrolled. And then, licensing, quality oversight standards, all of those things kind of still to be ironed out.
Okay, so if the jails ourselves are paying, say, our providers bill us directly, and then we as the jail are going to bill Medicaid, do we as the jail have to become a Medicaid provider in order to bill for the services?
In that scenario, I want to say no, because you're not, like, in that situation, you're almost acting as like the billing party and you're not the one rendering the service. And so I think what would be key is that the person the medical provider providing the service would need to be a Medicaid provider. And what we can do is we can take all the scenarios, like if you tell us that you're interested in having community-based providers provide service and bill, or your contractors provide services and bill, or you're interested in you yourselves as a facilities billing, we'll take whatever options you're interested in, and we can build out a use case and a workflow to figure out exactly what that looks like and what the requirements could be. What we want to identify right now is which of the options you're interested in exploring, so that we can, work through exactly what it would look like and be able to answer those really specific questions for you.
Okay. Thank you.
Yeah.
Just want to throw out, sorry, I had to
Yeah.
find the mute button, get back to the page. I would assume if you're subcontracting with the jail and are part of a behavioral health agency who bills Medicaid, it would just roll right in fairly seamlessly if there's already, if we're already like doing all the things to bill Medicaid on the outpatient facing side. Are there going to be do we expect there to be any major differences when it comes to specifically billing, rendering services within the jail?
If you're the medical provider is already enrolled with Medicaid and billing for services in a different setting for folks who are in the community, I think that that will be, I hate to say it, pretty simple, hopefully, kind of straightforward. I think, frankly, one of the biggest challenges when it comes to reentry services is, bringing folks into the Medicaid world who aren't familiar with Medicaid billing and what that looks like. And so if you have a medical provider who already knows what it's like to bill Medicaid, has the ability, has billing software, has all of those things, I think they would be in a fantastic position to start billing for these services. Would be the difference may be making sure that you're enrolled in the right provider type, things like that, to offer services in this setting. But that seems pretty straightforward, definitely something that could be relatively easily worked through for someone who's already used to billing Medicaid. Nancy, you asked if counselors would have to be Medicaid providers. Are you talking about for MAT counseling, or like counselors who might be doing some type of case management? I'll just answer both. So counseling and case management. So I think at the end of the day, if you're providing a service that you want to bill Medicaid for, the providers are going to have to be enrolled in Medicaid. Like I said, when we get some ideas about how it is that you want to approach this, we can get really nitty-gritty and work through these use cases about, if you have this type of provider billing this service, what it's going to look like, who needs to be enrolled, what provider type, all of those more specific things we can work through. And then Ray, you said, won't that matter on rate coverage per member and if the provider is contracted with that, Ray? So when it comes to the raise, when individuals are incarcerated, they are not attributed to a ray. And so the rays are not getting the per member per month payment that we typically send them. And the way that we've set up reentry services is that they are going to be billed fee for service, which means they will be billed directly to HCPF, and the provider won't bill the ray, won't have to contract with the ray, you just bill us directly. Where the raise will come in, I think, comes a little bit more to like information sharing, care coordination, making sure that they can be a great resource to make sure members have somebody to hand off to when they're going back into the community. And so I think raise will be a really important piece when it comes to that actual transition back to the community. But in terms of providing and billing services prior to release, it'll be through our fee-for-service structure. Michelle, I am copying down your question about like licensing and specific provider requirements when it comes to SUD. And we'll follow up on those answers. All right. So when, talking about the roles of the jails, clearly it can look like a lot of different things. There are going to be multiple ways that we can operationalize reentry services. At a base level, we note that participating facilities will need to complete a readiness assessment prior to being authorized to offer reentry services. And so the readiness assessment we're still developing, but the types of things that you would expect to see on there is needing to see that you have a Medicaid application process for Medicaid members. And then we'll be asking questions about how you intend to provide services. Exactly what we're talking about now. Is it going to be your staff? Is it going to be a contracted provider, a community provider doing in-reach? Kind of which path is it that you're going to take? Now, another consideration for jails, House Bill 241045, which is the bill that gave us the authority to apply for this waiver and do all of these things, does require jails that want to offer Medicaid reentry services to demonstrate a commitment to diversion or deflection efforts. Have not made any final decisions on kind of how we are going to, determine that requirement. What I would probably anticipate seeing is that somewhere on that same readiness assessment we were just talking about, that having a place to attest that you are demonstrating a commitment to diversion or deflection efforts as is required in that bill. Now, this is the funding source that I mentioned earlier that I would love to get some of your feedback on. So entirely separate from, typical Medicaid billable services, this is a federal CMS state planning grant opportunity that HCPF is planning to apply for. State Medicaid agencies have to be the one to apply for the grant, and each state agency anticipates being awarded between 1 to 5 million over a span of 4 years. The overarching intention of the grant is to increase readiness for reentry services. The bullets here, I apologize if they're a little small. I pulled these from an informational presentation that CMS did where they listed out examples of some of the allowable activities. When I read this list, it seems quite broad to me. Some of the things are addressing operational gaps to comply with statutory requirements, read CAA 5121, including working with relevant entities, establishing standardized processes or systems for activities such as Medicaid application processes that we were just talking about, allowing folks to apply for coverage while they are in your facility, establishing processes to submit claims, bill Medicaid, investing in bidirectional information sharing, and establishing oversight and monitoring processes. So these are examples from CMS of allowable activities for this grant. We are just getting running on creating our application. Colorado is applying in cohort 2. If you saw anything about this grant, they did just announce the awardees for cohort 1. Colorado did not apply with cohort 1. We're applying with cohort 2. So where we're at right now is just getting going on writing our application. And what I would love to hear from you all is, do you have suggestions on how we should prioritize this funding when it comes to writing our application for it? What do y'all need is the question.
Don't everybody talk at once.
I'll let the silence sit. I'd really love to hear how you all want us to prioritize funding as we think about what we should put in our application.
This is Brendan from Weld
Hannah.
County.
Oh, sorry, go ahead.
No, yeah, I think one of our priorities or challenges is just coordinating with other agencies, community members to meet these needs. So I'm not sure where that fits in there.
Can you give me an example of what you mean with like coordinating with other agencies? Not to
Just
put anybody
thinking
on blast, just make sure I understand.
Oh, no, I just think that like, I think as far as the sheriff's office's ability to provide targeted case management is probably something we can't staff. But being able to connect with someone in the community, establish agency that is able to come in here and help do that. And just, I was reading that CAA stuff, trying to figure out just manage the individuals that, that those people that have previously been in the foster care. I don't know how we're going to get those lists or identify those people. It sounds like what you're suggesting is this 1.15 is just going to cover everyone. So it wouldn't cover those people that were in the foster care program. Is that right? But then would we have to provide targeted case management for 90 days for that everyone? It's just, yeah, we're going to need some help, at least here at Weld, to coordinate and figure out who's going to do all that. Sharing lists like data, we're already kind of challenged with that with our DHS, like the outreach team, who's on a Medicaid, who's not on Medicaid. How do we get them the list of everyone that's incarcerated? How do they get that information back to us? Those are all the barriers we've been challenged with.
I'm hearing coordinating with community agencies who may be able to come in, provide services, information sharing in terms of knowing who is in the CAA target population, and then information sharing with DHS as well.
Thanks.
Cassandra, you have a hand up?
Yeah, so one of our things I think are medications and providing like medical treatment within our jail since we are super small and don't have a nurse.
I will note, so that is something that like MAT medications prior to release and all prescription medications upon release will become Medicaid billable services. And so one of the restrictions on the grant is that we won't be able to use funding for providing medical services since Medicaid, since that's already kind of under the scope of what Medicaid can pay for. It does have to be focused more on some of these like activities to get us ready to operationalize.
Okay.
Yeah. Jill?
So this is the Pueblo JBBS program. We have pretty good community relationships with providers as far as and we do, I mean, we work to do targeted case management with all the enrolled people, but I think I kind of feel a little bit with Weld County that if we're offering it to every single person in the jail, then yeah, we definitely need additional resources and help in order to offer it to every single person. And so I think we would need Medicaid enrollment benefit specialists working with every single person in the jail at booking. So that would be I think a monumental task to worthy of support from the planning grants. I know.
Thank you, Jill. Kelly and Becky, when the meeting ends, it'll send you a copy of the chat, right?
Yes, it will.
Yeah, it should.
I started copying things out of it and I was like, I can't do this. There's too much good stuff in there. So I'll make sure that I get everything, any of the feedback that y'all are putting, in the chat as well. I see there have been a number of, suggestions come through.
I'll make sure you get that chat, Hannah.
Thanks, Becky.
That usually comes through before the recording, so I'll send it to you.
Okay. Yeah. I'm hearing a lot about the Medicaid application process from Weldon, from Pueblo.
Yeah, that's kind of a, especially for our smaller jails, and even for the larger jails, honestly, like the Medicaid enrollment process while in custody is definitely layered. And
Yeah.
so yeah, I'm gonna need a lot of help.
And Hannah, all the comments in the chats seem to be regarding the county health department. So Nancy is with Prowers, Michelle and Jennifer here in the chat are with Elbert. And then you have Laura in El Paso. So it's smaller counties and bigger counties. And I know you've touched base with Michelle in the past. They continue to have issues with their DHS folks. So it sounds like big counties and little counties continue to have issues with enrollment.
Will our DHS be required to help, or is that more on a like voluntary basis?
What a great question. So in terms of, I mean, when it comes to processing applications, they are currently required to process the applications that they are receiving from you. They have to process applications. They have a 45-day, currently their rule is they have to process applications within 45 days. I know that is a very long time when we're talking about folks moving in and out of jail quickly. And so I think it would be great for us to explore what we can do in terms of getting more active partnership and participation from the DHS counties for the jails. But just in terms of at least like processing applications that they're receiving, that is something that they currently should be doing. I'm hearing that it's not always happening. But that is already a requirement of them that, you know, Medicaid or that incarceration status should not be negatively impacting the processing of their applications. We have a hand up. I believe.
Yeah, my name's Torrance, as you can probably tell from the tag. I work up in Moffat County, and I guess I just wanted to share, like, when I'm able to sit with people and create a profile with Peak and do the application online and make sure to check that they are incarcerated. Every time that I've done those steps in the past few months, as soon as the application is submitted, their Medicaid is active immediately. So obviously not everybody has that ability to personally sit with people, have internet access, make their profile and all that. But that is a process that I've found that is extremely helpful in that space. So just wanted to share that.
Yeah, thank you for sharing that, Torrance. Maybe I can talk to you more, just kind of document your process, and we can use that as an example for folks. I think at the end of the day, when it comes to Medicaid application processes, we're going to have some minimum standards when it comes to the fact that it has to happen. You know, Medicaid applications will have to happen for folks for them to become Medicaid members, and then for us to pay for those services. But we know that there's going to be flexibility required, that the same thing is not going to work in every county. But yeah, if I could, you know, collect from some of y'all who have a process that is working well, examples of what that workflow looks like, then we can, you know, share, hopefully do some more information sharing just in terms of what can this process look like, what has worked in other places. And Peak can be great, like Torrance said, for a lot of folks, especially someone who is incarcerated and has zero income because they're incarcerated. Their application can be pretty straightforward. And oftentimes, if done online, you'll get real-time eligibility and you'll know right in that moment, kind of what their determination is. Any other feedback or thoughts that you want me to take back in terms of how we use these planning grant funds? All right, I'm gonna keep going. That hour seems like so much time. Oh, Jill, sorry, go ahead.
So in mentioning the internet access and the Peak website, maybe a possible use of the grant award would be to upgrade that capability within even large or small facilities so that inmates do have restricted secure access to the internet, that they can do this themselves, like they can go on Peak, create their plan, because otherwise that was my other suggestion, is to have enrollment specialists that can sit down with each individual person. So if you use technology instead in the funding to be able to provide what the jails can accept as limited, like lockdown internet access to one website, Peak. And then they can do it themselves. Like you can say, hey, did you enroll in Medicaid yet? And they can say, yeah, I did it. So that would be the other option. If you don't do that, then you're going to have people sitting with an inmate at booking or shortly thereafter to process an application. And those will have to be like physical paid people.
Yeah. Cassandra?
Sorry. And then I guess this would be a question more for Kelly and Rebecca. So if we get kind of the Medicaid stuff set up, would it be a requirement for individuals to participate in JBBS to fill out Medicaid paperwork?
It sounds like that would probably be that probably would be a question more for Hannah. I'm assuming that the answer would probably be yes. Just especially for the sake of a transition and all that kind of stuff. But I'm not sure.
I mean, they would have to fill out the Medicaid application and be a Medicaid member for us to like pay for MAT, for example. But in terms of participating in JBBS at large, I guess I would maybe turn that back to you, Kelly or Becky. I mean, you don't have to, I don't think you restrict your program based upon Medicaid or, any of that.
No, and I guess like if somebody's just going to be getting some re-entry, if you're giving somebody a backpack or something upon release, I think that wouldn't necessitate necessarily somebody on Medicaid. But I think, we want this to be able to help as many people as possible. So I not really knowing exactly what this is going to look like as it rolls out, it should probably be something you should be doing. I don't think that we will or can make it a requirement, but it's something that you probably should be doing.
I think as we flesh out, and, write specific policies and workflows and how this is going to play out, that's something that initially I feel like would probably fall more into like a best practice category rather than a requirement. But I do feel like that would come down to the JBBS team. We wouldn't Medicaid's not going to make any decisions about, what someone has to do to participate in JBBS. Okay, I'm gonna push us forward. This slide basically says that we want to engage with you, and we started and we want to keep doing it. And we have some poll questions about what you all want that engagement to look like. Becky, I think you have those set up. I don't know how to make them go.
I did. Let me. This will be my first time doing these, so we gotta. So I can. Do you want me to launch them all at once or just one at a time?
Let's just go all at once.
Okay. All right.
See if it works.
Let's see if it lets me do that.
I don't know if
Oh,
that's
nope, I can only launch one at a time. So I'm gonna launch the first one. That one should be launched. Did you all get that?
I'm seeing it.
All right. So if we could answer that and let me know when we can close it.
Okay, so we have a number of poll questions. Really want to hear from you. The main goal of this meeting, as we know, or maybe I should have said this at the beginning. We know we're not going to make a lot of final decisions today. I want this to be the start of continued engagement, and hearing from you all on how you want this engagement to continue for us to plan out reentry services. That's what these questions are getting at. And then we have a few more discussion questions. We've already had a lot of great discussion, but we'll probably keep going until Becky tells me to stop.
Well, it looks like we've got 30. We still got responses coming in on this one. So it looks like folks are favoring a new meeting series on this topic.
Okay. And what's going on?
Yeah, we've got agendas on existing meetings and email updates pretty much tied. Nobody likes to review draft policies. Got it. Got it. All right.
Nobody wants to read my Medicaid nonsense. Is what I'm
All
hearing.
right. Well, we haven't had a few responses coming in a sec, so why don't we all of the above? Commander Youngklaus is wondering why all of the above is not a choice.
That's a great question.
Because Hannah didn't give me that choice, Commander.
It's my fault. I'm noting though.
So you got one. Yeah, one person wants all of the above.
I'm noting that
right.
the commander will review my draft policies.
Well, we haven't gotten any more responses, so it's looking like a new meeting series on the topic is good for this one. So
Okay.
would we like to end this one and move on?
Yep, let's do it.
All right, we'll go ahead and end this one. And share results real quick. Everybody can take a peek at that. Let me know if these aren't popping up as well, because this is literally my first time doing this. All right, we'll close that. All right, then we're going to go back. All right, next polling, next topic. Here we go. We'll launch this one. For Matt and case management, would you be interested in exploring any of these options? Are we seeing that one? All right, we are. Okay. All right, we got responses coming in.
I didn't put in all of the above on this one, but I did put other, so maybe a step in the right direction.
And if you do mark another, please explain. Take yourself off mute or explain in the chat. Got two others, so.
Yeah, please feel free to come off mute now and just let us know what you're thinking.
So it's looking like folks are like billing for services provided by medical vendors and jail staff.
Mm-hmm.
We're still getting a few responses for allow community-based providers to do in-reach. We have 4 others. Could you all please take yourselves off mute and let us know what your other is?
This is Brandon with Weld. I selected others just because I'd be interested in exploring a couple of those options up top.
Okay. So that's an all of the above
Yes.
type answer? Yeah, got it. Okay. Thanks, Brandon. Yeah, Jill?
Oh, go ahead.
So I think the decision here would have to come from the jail command staff, like whether the county wants to take on the extra task of billing Medicaid, or if they want it to all filter through the medical contract provider. When is that provider that there could be a new contract for our medical services at the jail. By the time this is implemented, we could be dealing with a totally different contractor. We already do in-reach services by local providers. We already have 2 programs in the community, one of which is already in the jail, and one we need to work that out. But it could end up really being like an all of the above kind of thing. It sounds simple to say the contract provider for the jail would bill Medicaid, but there could be places where the county could recoup expenses. And then Hannah is saying those are going to be reinvested in our community. So I think there's really not the right people at this meeting to answer the question for Hannah.
And Jill, one thing I want to add that I realize is not clear now looking at this question, is that I'm not just going to take like the one top answer and run with it. We don't have to choose one of these pathways for all of the jails to move forward with. Seeing that y'all are interested in like all three of the ways that this can work, we'll explore what the process should look like for any three of these options. And then that is a decision that would be made at a jail level in terms of how your specific jail wants to provide these services. So I just want to make it clear that we're not choosing, right now the one way that this is going to work. Just interested in seeing what y'all's preference is. And seeing a lot are selecting medical vendors, but all of the options are being selected. And so we'll move forward, identifying how any of these three options or a combination of them would work.
Thanks. We're going to go ahead and wrap this one up because we do need to wrap up. We do have one more presentation after this. So we've got a couple more poll questions. Thanks, Commander. We've got a couple more poll questions. So I'll go ahead and end this one. Share the result here with everybody so everybody can see that super fast. As Hannah said, we're kind of going with everything right now. Everybody wants to see everything right now. All right, poll question number 2. We'll launch this one. This one's pretty quick. Actually, that one's not letting me launch. What's going on here? Oh no, it's not letting me launch this one. Oh no. A poll has been shared in this meeting. Yep, because oh, here we go. All right, that would be why, because I didn't stop sharing. All right, here we go. So do you have an entity or organization in mind that would do this work?
I'm talking on mute. If anybody wants to come off mute and quickly share what organizations they're thinking of, please feel free.
We're favoring no at this point, Hannah.
Oh, yeah,
It's looking like it's only 12 responses are saying yes, so we've got 19 on the no front. All right, we're gonna go ahead and end this one and share real quick, so we can go ahead and move on. So here's this one. So yeah, it looks like most folks do not have an organization in mind that would do this at this point. If you do have an organization in mind, if you could pop that in the chat while we're doing the next one, that would be awesome. And then I can get this, I'll get the chat to Hannah. All right, so let's move on to next. Overall, how prepared are you to incorporate Medicaid reentry services? Let's go 0 being not at all and 5 being very prepared.
We've got a couple people here who are real confident. I like it.
You got 3 that are pretty confident. Looks like we're not feeling too confident though for folks. We're at mainly 2s, 1s, and a couple of 0s. Thanks, Nancy. Popping that in the chat. All right, I'm going to close this bad boy in 3, 2, 1. And this hand, I'll share this one. So we're mainly favoring, we're not feeling too confident about this at this point. All right, we ready to move on to the next one? All right, we've got one more. This is the last poll. How familiar are you with insurance billing processes? So while this is going, Polly, to answer your question, do we foresee the 1115 waiver impacting the funding we provide to jails? Partially, yes. So some of the JBBS funding will be going to the Medicaid agency to cover this population. So a lot of your folks that would be considered JBBS would meet criteria for Medicaid with this reentry waiver. And so we would be providing some of that funding to HIGPUF to cover this. We will still have JBBS funding. Our funding may look different. Our funding may look more flexible. We may be applying for more grants as well to cover things. But this is something that you all essentially, in order to cover your general JBBS population, this is something that jails will need to do in order to cover the folks that you are currently covering. Because JBBS will not have the bandwidth to cover the same folks that we're covering now, because a lot of those folks will meet criteria for Medicaid. All right, so it's looking like most of our responses, Hannah, are not at all familiar with billing processes. So we're gonna go ahead and end this. We're gonna share this with everybody. Can everybody see that? So we're mostly zeros, that we are not at all familiar. Couple 5s and 4s.
Heard.
Yeah. All right. Well, that is the end of the polls.
Thank you so much, Becky.
Absolutely.
I know we're coming up on time, so I can end here. The one thing that I would ask of you all, and I can put this in the chat as we transition over to your next presenter for today, is to respond to number 5. I have a very, very simple, very straightforward Google poll just asking who you want your main point of contact for Medicaid reentry services to be. We heard in poll question 1 that your preference moving forward is to have a new meeting series on this topic. So if you could identify me who you want each of your county's main point of contact to be, that would be incredible. And then I'll use that list of people as we move forward with our engagement. And we can save these discussion questions for the next time we come together on this topic, knowing that we're at time. The rest of these slides is resources, links. Y'all will have access to this.
Awesome. Thank you, Hannah. And I do have a copy of the presentation, everybody. So I will go ahead and I can send it out. Or Hannah, provide you with the contact list. Maybe just shoot me a message and let me know what you would prefer. But we will get this presentation out to everyone. And this will not be the last conversation. We will keep having these. Keep inviting Hannah. You guys also asked for additional meetings, so we will be scheduling additional meetings as well. Outside of these meetings, we'll make sure you all are involved in this process. This is something that we need you all to be involved in. So we appreciate Hannah. We appreciate you. We appreciate everyone's responses and questions today as well.
Yeah, thank you all so much for the time and the engagement. I'm just gonna put the link to that form to fill out who you want your contact to be. Thanks so much.
Thank you. All right, we do have one more presenter. So Jennifer, are you here today?
I sure am.
Awesome. Jennifer, I made you a co-host a little bit ago because I know we were trying to get you on here. So Jennifer is with R1 Learning. Jennifer, I'm going to go ahead and allow you to do your own introduction as well. And I'll go ahead and let you have it.
Absolutely. Thanks, Becky. Well, hey guys, my name is Jennifer Gerse and I am with R1 Learning. I am going to go ahead and post a super fast chat in the chat, so you'll have some information there. But I am joining you with my colleague, Frank Baumer. We are both with R1 Learning, and R1 Learning is an interactive curriculum tool that's meant to help with mental and behavioral health programs in the correction setting. So I know we have about 15 minutes left, and I promise you I won't take all 15 minutes. My goal is to provide a very high-level overview of the interactive and dynamic tools that we have to support your programs, give you a taste of what those tools look like, and hopefully, if you're interested, I will have the opportunity to meet with you one-on-one. So I did post my meeting link in the chat for anybody that schedules some time with me. I will make sure you get some free, yes, I said free product as a result of your time. So with that being said, Jennifer Gers, I work really on the sales side here at R1 Learning. Frank, my colleague, is our Chief Technology Officer. If you've got any questions, post them on chat and he'll help me get those answered ASAP. So with that said, guys, I am going to share my screen. And Frank, if for any reason there are technical difficulties, interrupt me and I'll correct those. So with that said, guys, we are R1 Learning. At our core, we are a curriculum company. And what we've done is we've built interactive curriculum that's going to tap into different modalities that are going to include hands-on cards and also a digital version. Now, both of those options can work independently of one another. In other words, we have some correction facilities that only buy the hands-on cards. We have some that subscribe to our digital version, and then we have some that do a hybrid of both. So very quickly about us. R1 Learning is building topics for mental health awareness, substance use, and also life skills. These are going to be some communities that we serve. We did get our start in the behavioral health community, but as our content library expanded, we grew into corrections. And actually, it was the state of California that found us for our resources and how we could support their peer support programs. And as a result of that, they are rolling out across 46 of their facilities across the state. So as it pertains to how we serve a need in the corrections community, these are going to be some areas that we address and enhance. So R1 Learning is built as a highly structured system. We are all about enhancing your programs. So our specialty is not the content. Rather, what we've done is we've taken that evidence-based content and we've built a hyper-modular structure, a structured system around that. And so what we find the benefits of this model is that, again, we're super modular, which allows us to be plug and play. It allows us to be easy to learn. And once you learn us in one area, it's going to apply to the rest of the curriculum. And finally, it allows us to be easier to train on and scale. So we have a library of content. Again, we're not making stuff up. Rather, we're taking the evidence-based models and theories in behavioral health, and we're building hands-on tools. So all of our content is thought leader driven. And we're really trying to gamify that content to drive engagement. So whether you're doing one-on-one behavioral health groups or one-on-one settings, or groups as a part of your behavioral health programs, what we work to do is get that individualized learning for each individual participant. So we are growing in terms of the topics that we have available. We currently have about 20 topics with 80 different curricular activities with a roadmap that's going to reach over 50 topics with 200 activities. We did get our start with decks of cards. And if anybody has been to a conference, if anybody's going to the Winter Symposium in 2 weeks, please stop by our booth. We'd love to say hi and show you our decks of cards. But we started with cards because we knew they were hands-on and kinesthetic, which help ground and focus individuals. We understand that cards are concrete. They're interesting in that they can tap into an individual's curiosity and creativity, as well as being logically oriented. Basically, our cards are going to put our individuals in charge of their own learning and build intrinsic motivation. So when we look at some examples, this is going to be an example of a topic that we include, in this case, emotional triggers. You're going to notice that the cards have one-word statements, and we keep the reading level no higher than a 7th grade level. And we find that that makes the cards easy to process because of the one-word or short statements. This is going to be another example of a topic that we have: substance use. We have values, recovery capital. The list goes on and on. So we do package our content in what we call group kits library, which allows you to have multiple decks of cards on the same topic. And also it comes with a facilitator guide. The facilitator guide really acts as a Cliff's Notes version of the research. And the facilitator guides are also going to have lesson ideas or activities that can be done either in one-on-one settings or in group settings, as well as some examples of just some good questions for engagement. Now, I can't show you a representation of our kinesthetic decks of cards, but what I can do is show you an example of what the digital version looks like. So this, by the way, is called R1 Discover app. And this is our digital content library that sits within the platform. Obviously, in the correction facility, we're going to operate on those tablets. And each individual user is going to create, of course, data as they engage in our content. Data will roll up so that you can have reporting over time based on just what information is being gathered. So what I want to do, guys, again, for the sake of time, is I want to show you an example of what our digital content looks like. You can then use your imagination to understand that this would transfer into our physical decks of cards. So as we look at our topics library, you're going to notice that we have quite a number of topics available. And again, our roadmap is growing to include over 50 topics. Let's say that we wanted to pop in and maybe look at stages of change for substance use disorder. What we have the ability to do is do an introductory video. These are going to be short 2 to 4 minute videos that are going to introduce the concept. There are multiple activities that accompany a topic. So in this case, let's go ahead and just start with a basic activity, and that's going to be identifying my stages of change. And so what we're going to do here is we're going to think about a specific substance, and we're going to sort our cards into 2 piles. So as it pertains to, let's say, my relationship with alcohol today, is this statement either true or false? So think swipe right, swipe left. Now we're going to do a random kind of picking and choosing of the cards here. As I kind of click through these, I want you to think about how engaging this might be. So imagine we have a group setting. Everybody's got their own individual either deck of cards, or if we're doing this digitally, they're going to have their own account. But there's a lot of thinking, a lot of internal dialogue and conversation that's occurring as we sort through these cards. Maybe aha moments that I'm having, new ways of thinking. So what I've done there is I've sorted through the 40 cards. Obviously, in a live setting, this might take 10 minutes, 15 minutes. That can depend. Now, I selected a lot of yeses because, quite frankly, I wasn't paying attention to what I was doing. But regardless, what we're going to do is we're going to take our yes cards, and we're now going to be tasked with narrowing this down to 10. So again, we're now taking all of the statements that resonated. We're going to choose our top 10, and we're going to go to our last step here. We're going to take these cards, and we're going to organize them in order from the one that most resonates all the way down to the 10th one that resonates. And at this point, we would have already seen that evidence-based model as a part of our introduction in that video. We're going to take a really quick peek at that. And now let's go ahead and go to our results. So as I look at all of the individual work that I just did, I'm now starting to get information based on where I'm at and the stages of change based on the activities and the work that I've done with my individual deck of cards. This, of course, was all random, no rhyme, no reason. But my hope is that you're seeing here just an opportunity to have a different, innovative, fresh tool that's still going to hit on those important topics in the mental and behavioral health space. So I promised a fast overview. That is really what I've got to show. My hope is that if you saw something that resonates, you'll click on that calendar link that I've put in the chat. Gives us an opportunity to find 30 minutes to connect at a later time. And again, I promise I'll get you some free resources. So with that said, are there any questions that you might have?
Looks like we're not, excuse me, not seeing any questions in the chat, but I would highly encourage you all to reach out to Jennifer to see about implementing this in your facilities. I was able to meet her at the ACA conference this year, and that's where we connected. And I think this is a great opportunity, and it's very interactive, and it's a great program for those who are struggling with these issues that are highlighted in these cards. So I would encourage you to reach out to her. I put in the chat, this would be an allowable JBBS expense if any of you are interested in moving forward and purchasing this program and implementing it in your facilities. I think it's a great opportunity.
Kelly, thanks for mentioning that. And I'd like to say, yeah, I mean, we have jails across the country that are really starting to discover us. And it's been really exciting. Frank, was there anything you were going to say?
No, I mean, I think you summed it up, right? We are an evidence-based interactive curriculum, right? Help people better understand where they're at through the lens of all this beautiful research, right? These research models and theories in behavioral health. So as Jen said, we're a modern kind of innovative engagement solution that can be used in a number of different programs in your facilities. So we would love to connect with you all and explore if this is a solution that would support your programs.
Awesome. And I just dropped my email address in there as well. But we certainly appreciate your time today.
Awesome. Thank you, Jennifer. Thank you, Frank.
Awesome. Thank you.
For everybody else, we are at 11:59. Like, my goodness, look at that. That is perfect timing. We appreciate everyone's feedback, questions, participation today. There was a lot of information today. Please feel free to, once we get the video posted, to review the posted video. Also, please just reach out with any questions or concerns you may have with the information presented today. There will, like I said, there will be more information presented on the 1115 waiver. We're going to continue to discuss this. It's something that we will continue talking about. With that said, I'm going to go ahead and stop the recording, and we will go ahead and wrap up for the day. Our next meeting, real quick, we have the GAIN Civicor office hours for anybody that has anything to do with GAIN and Civicor on January 29th. And then we have our next roundtable meeting specifically for jail personnel. I'm trying to talk slowly while I bring up that spreadsheet. We have that meeting on February 12th. So that is for jail personnel, that roundtable meeting. Our next learning community meeting with everybody here will be March 12th. So you will be getting invites for those and holds for those fairly soon. So with that said, again, thank you, everybody. Appreciate it. Have a great rest of your day and a great end to your week. Thank you.